So one other thing that I would just want to make sure that we give the opportunity for any legislator who might be with us to say a few words. And Shannon, I don't know, excuse me, Melissa, I don't know if you would have the opportunity to see anyone who has their hand up. If a legislator is with us and wants to say hello, that would be great. Melissa, would you be able to see that?
Yes, they can use the raise hand function, and I'm searching now through the guest list. But if there is someone, they can raise their hand. And we have Jim Heffernan who's raised a hand.
Yeah, please go ahead.
You
Okay, there we go. Can I start
you.
my video? Okay.
Good.
Okay, I'm 77 years old. I've been on Medicare for 12 years. And I have a COPD, which requires me to take 2 inhalers. I also have a tendency to slip into atrial fibrillation, not for years, thankfully, but I have 3 medications that my insurance doesn't cover for beans, really, as far as I'm concerned. Xarelto for a blood thinner is covered by my insurance. But my copay is $398 for a 3-month supply, and that smarts a little bit. I'm wondering about going back to warfarin, even though it's an inferior medication, just because rat poison is a lot cheaper than Xarelto. And then I also have COPD, which has 2 inhalers I'm prescribed, which my worthless insurance company, WellCare, doesn't cover at all. And if I go to Freddy's to get my prescription for Spiriva, it's $606 for a 3-month supply. I can go to Canada and get the same drug coming from New Zealand for $333 for a 3-month supply. And then there's budesonide, which is another inhaler, which cost me at Freddy's $479 for a 3-month supply. And I can get it in Canada for $369. I kind of I wonder if I should have looked at my insurance a little bit harder when MOTA kicked the Medicare Advantage people to the curb this January, but there it is. I just think that's, those prices are very hard. It makes a difference in what I can afford and what I cannot. And I just think there should be a better way.
Thanks a lot for your comments. Any other legislators who want to say hello? Okay. Thanks a lot. So
okay, will this recording be available elsewhere?
Yes. It will be on the website. It will be on the PDAB website. So, yeah.
Yes, because I think I have to leave actually about 40 after 12. I wasn't expecting 2 hours.
Yeah. Okay. No, it'll definitely, and I'll go through that again at the end of the session. But yes, it will be on the PDAB website, and we can get you that information.
Okay. Thank you.
Yeah. Okay. So looks like there are no other legislators who would like to say hello. So let's just go ahead now. Melissa, second slide. So why are we here? As Shelley mentioned, hearing from you about the challenges you're having with the cost of your prescription drugs is really crucial to the board's work. As I mentioned earlier, we thought it would be helpful for you to hear a little bit about the background about PDAB, as well as the issue of upper payment limits and the cost of prescription drugs generally. Next slide. Next. Yeah. So PDAB was created in 2021 because Oregon legislators were very concerned about the impact the high cost of prescription drugs is having on Oregonians and the healthcare system. The board is appointed by the governor and confirmed by the Oregon Senate. Next slide, Melissa. So PDAB has already done some important work on behalf of Oregonians. The board recommended to the Oregon legislature that it lower the insulin copay limit to $35 and or decouple it from the inflation index. In this last legislative session in February, the legislature passed Senate Bill 1508, which caps the cost of insulin to $35 a month and limits the cost to $105 for a 90-day supply. This is probably a good time to emphasize that the board does not have the authority to make decisions on prescription drug pricing. It makes recommendations. The legislature makes those decisions. It would go through the usual legislative process with both the Oregon House and Senate passing the legislation and then signed by the governor. Next slide, Melissa. Got it? Great. So in 2023, in response to recommendations from the board, the Oregon legislature passed Senate Bill 192 to create an implementation plan for upper payment limits and to increase reporting requirements for pharmacy benefit managers to improve transparency. Next slide, Melissa. So this is where you come in. In addition to developing a plan to establish an upper payment limit on prescription drugs, SB 192 directed the board to seek public input on the effect of the rising cost of drugs. This is something the board has a deep commitment to, as Shelley mentioned. And if there's any question, it's also in statute. Senate Bill 192 is law now. Next slide. Got it?
Okay. There we go. Sorry about that, Lou. Having some mouse trouble here.
Okay. So what's an upper payment limit? This is a simple definition, but I think it works well into describing it. So an upper payment limit is a limit on what purchasers in the state will pay for specific drugs. It creates a ceiling on what a payer can pay for a drug. It does not set the price a manufacturer can charge. Next slide, Melissa. So let's get into the issue of prescription drug cost. Most of you probably know this already, but I think it's good to start with some basic definitions. A prescription drug is intended for the diagnosis, cure, mitigation, treatment, or prevention of disease. A brand name is covered by a patent for a set period of time. A generic has the same ingredients as a brand name and is available after the patent has expired on the brand name. Generics usually cost less and are used more frequently due to the cost. Next slide, Melissa. So the high cost of prescription drug impacts us in three ways. The first is the one that we read about and know from personal experience. It's the reason why some of you are here, and that's the out-of-pocket cost to the patient. Next slide, Melissa. So the information on this slide comes from a public opinion survey. What's particularly significant to me is that 28% say it's difficult to afford their prescription drug medicine. And 40% of those have a household income of less than $40,000. About 3 in 10 of those folks who took the survey haven't taken their medication as prescribed due to the cost. Next slide, Melissa. So another impact on the high cost of prescription drugs is the impact it has on the state of Oregon's ability to maintain public health programs. So even if you're not on the Oregon Health Plan or you receive your health insurance as a public employee, guess what? You are paying for it through your taxes. So when the state needs to pay high prices for prescription drugs, it actually does impact you. Next slide, Melissa. So the third leg of the high cost prescription drug stool is insurance premiums. Folks may not have large deductibles or co-payments, but if a consumer is prescribed a high cost drug, someone is paying for it. It's reflected in your insurance premium. So how do prescription drug costs affect premiums? Next slide, Melissa. Well, it depends on who you ask. So we have two views here. AHIP, which is the National Association of Health Insurance Carriers, says that over 22 cents of every health insurance dollar goes to prescription drug costs. PhRMA, the national organization that represents the pharmaceutical industry, says that number is 15.3%, or 15.3 cents of every dollar. You get that number by adding brand medicine and generics on PhRMA's chart. So we can split the difference, and that comes to slightly under 19 cents of every premium dollar. So that's just shy of 20%. Next slide, Melissa. So why is it so difficult to pin down the reasons for the high cost of prescription drugs? This is a diagram of supply chain for brand name drugs. I'd say it looks like the back of an old television set, but without seeing all the faces, it's likely that a lot of you don't really know what that means. And I'm not going to go through this diagram today. It actually would take quite a bit of time and a certain amount of technical knowledge, which I actually do not have. But you can see how complex it is. Next slide, Melissa. So this slide will give you an idea as to how many participants there are in what we call the prescription drug supply chain. So we've got manufacturers, wholesale distributors, pharmacies, pharmacy benefit managers, insurance companies, medical providers, and then consumers and government agencies. A very complex system. Next slide, Melissa. So why are prescription drug costs high? There are a number of different perspectives on this, and here's just 3. Next slide, Melissa. So AHIP, who we heard from earlier about the percent of insurance premium that goes to prescription drugs, thinks that coupons offered by pharmaceutical manufacturers contribute to the high cost of prescription drugs, as it removes incentives for patients to use lower cost drugs. Next slide, Melissa. The Initiative for Medicines, Access, and Knowledge, which is often referred to as IMAC, thinks that the patent process plays a role. There are 74 patents on each of the top 10 selling drugs in the US. IMAC sees this as a way to keep generics and biosimilar competitors off the market, with the result that consumers in the US pay an extraordinary amount for these drugs. Next slide, Melissa. So the Oregon State Pharmacy Association, which includes lots of your local pharmacists, sees a problem with the pharmacy benefit manager, otherwise known as PBM, that system. Pharmacy benefit managers negotiate prices with health insurers and pharmacies. Their fees and incentives contribute to the cost of prescription drugs. PBMs steer patients to their own affiliated pharmacies for their own profit, resulting in increased cost of care. PBMs gain profit from price spreading. In price spreading, a PBM charges a medical clinic more for a drug than it pays the pharmacy where it obtained the drug. The PBM keeps the difference as profit. And this is the view of the Oregon State Pharmacy Association. Next slide, Melissa. So here's some information that speaks to the issue of managing prescription drug costs and the issue of upper payment limits. Drug manufacturers argue that the cap on costs would impact their ability to research and develop new drugs. The information on this slide was provided by the drug manufacturers. The numbers speak for themselves. 1/3 of the manufacturer's costs for brand name drugs are devoted to advertising. Would they need to cut down on research and development if there's some cap on costs? Well, I'll let you decide that. Next slide, Melissa. So now we want to hear from you. The board wants to hear about the financial challenges you're experiencing with the cost of your prescription drugs. This is not limited to the drugs the board is reviewing at its board meetings. We want to hear about any prescription drug that is causing financial challenges. Next slide, Melissa. So here are 3 questions that may help you to think about the challenges you're facing. You don't necessarily need to answer these, but they may be helpful in getting the conversation started. So if you're willing to share with us, that would be great. There should be a hand-raising function at the bottom of your screen. We also have surveys which are available online. So even if you've shared your story with us today, or if you're reluctant to share your story with us today, we encourage you to fill out a survey. We'll have a slide a little later with an icon that you can click on with your camera, and it will take you directly to PDAB's website. The slide will also have the website on that slide, if that's easier for you. Well, the surveys are voluntary. They're also anonymous, but the information will be collected and combined to hopefully provide some useful information. This information will be publicly available. So here's how we would like to do this. We first want to hear from folks who have experience dealing with the challenges of the cost of their prescription drugs in Oregon. As I said earlier, this is not limited to the prescription drugs that are being reviewed by the board. If we have extra time, we'll hear from advocacy groups on behalf of Oregon consumers who are having challenges with the cost of their prescription drugs. So as I mentioned earlier, this is not a forum on healthcare generally. It's really not something that Prescription Drug Affordability Board has any authority to review or make recommendations to the legislature. So as much as it's a concern to all of us, it's simply not useful to discuss it today. So please be respectful of that and of others who are testifying. I shouldn't say testifying, they're actually telling their story. As I said earlier, I'm going to ask if we have your permission to record your comments, and it is perfectly fine for you to say no. So if you are an individual consumer who is experiencing challenges with your prescription drugs in Oregon and like to share your story, please raise your hand, and Melissa will find you with your hand raised, and we'll get you on to talk about your story.
We have Lou, we have Michael Quiner, and Michael, you should be able to turn your camera and your mic on.
Michael, thanks a lot for your willingness to share your story with us. Is it all right if we record you?
It is all right if you record me.
Great. Okay. Thanks a lot. Go ahead.
Thank you. Thank you for doing this forum. My name is Michael Quiner. I live in Albany, Oregon, in Benton County, and I've been diagnosed and living with multiple sclerosis for 20 years now. Multiple sclerosis, for those that aren't aware, is a unpredictable and it's an unpredictable disease of the central nervous system, including the brain, the spinal cord, optic nerves, and MS disrupts the flow of information with the brain and between the brain and body. And different people have different symptoms and different flow of the course of their disease. My symptoms include the ability to walk. So I have severe foot drop. I have problems with my eyesight, problems with temperature control, fatigue. And I went on disability retirement from my job as at a community college about 2 years ago. At that time, I had to change my insurance, and I went with the Oregon insurance marketplace, and that has basically added tens of thousands of dollars per year for my prescription drug costs. I take a disease modifying therapy called Rebif for my multiple sclerosis. One thing I learned very quickly was that while insurers in the Oregon marketplace will cover you regardless of pre-existing conditions, that doesn't necessarily mean that they cover your medication for those pre-existing conditions. Rebif is very expensive. It costs about $7,000 a month without any kind of help, and the insurance does not cover that much. So that has been a challenge. As we like to say in my household, we're on a fixed income, and they fixed it good. One cost that is perhaps not seen quite as frequently is the cost of time required, and the fact that changing insurances may require a delay in your treatments because of paperwork needing to see schedule with different physicians, neurologists, and then going through the system so that they can get approval and approve the medications that you need. So besides financial costs, there's also time costs. And I noticed that one of the questions was, can you follow your medical treatment plan? Sometimes it's not the cost that slows you down from your medical treatment plan. Sometimes it's the time taken to get approvals and work through these pharmacy systems. I would just say that Oregonians, especially those that are dealing with the disability, or they're elderly, or they're veterans, or they're in some other underrepresented community, they need reasonably timed access to reasonably priced medications.
Thank you, Michael.
Do you have any questions for me?
No, you've been very helpful. You gave us a really good summary. Thanks a lot.
May I make a comment to Mr. Quiner?
Sure.
Okay, thank you. Well, first of all, thank you for sharing information related to your personal story. I also wanted to reinforce, I really heard your comment related to time and your essentially time and the opportunity cost of your time. I've heard a lot of people present and have spent my career doing this too, but that is a specific comment that is not something I've heard before and framed in that way. So thank you for sharing your information, but also thank you for sharing, because you're right, it becomes a job and it takes you away from other work you could be doing. So thank you very much for sharing that part of your perspective as well.
You're welcome, and thank you for this opportunity.
Absolutely.
Melissa, do we have anybody else with their hand raised?
Yes, we have Alex Johnson. So, oh,
Great.
let me change the setting for Alex Johnson, and Alex is the mayor of Albany.
Alex, can you hear me?
I can't. Yeah, there I can now.
Oh,
I might.
good,
I
good.
can. I might turn my camera on, but it's not. There it goes.
Oh, there
Hi.
we go. So are you,
Um,
is it okay if we record your comments?
Of course.
Okay, good.
So I am the mayor of Albany, Oregon. However, for the last 15 years, I've been a broker of insurance, specifically Medicare. And one of the things that I've constantly do, I find clients, people that get medications that are, like the gentleman mentioned earlier, are expensive, like Eliquis. There's so many of these drugs that are really ridiculously overpriced. But I found that if they had an agent that would do the research for them, they can help them get exceptions to the formularies. But my concern is that Eliquis patent had expired, and they're supposed to become a Apaxaban, which is a generic drug, and they were able to get an extension from the FDA for 5 years. So we need to have a way that we cannot extend when it comes off patent and should be a generic. There shouldn't be any way for a pharmaceutical company to get around that. You know, getting protection from the Congress to keep the FDA keeping these drugs at an extremely high cost is hurting my clients. And I have clients in 20 states, and every year we have to go through the process of looking at their medications, seeing if we can get exceptions, seeing if we can find a lower cost alternative by working with them and their doctors. And a lot of times medications are counterproductive to the medications that they've been prescribed by another carrier. So we need checks and balances where if a doctor's prescribing this medication and another doctor prescribed this medication, there's no communication between the two, because one drug may counteract the effects of the other one. And also, or it could also reduce its efficacy and for us caring for that client. So it's a big concern for me. And I do feed information to Senator Wyden and Senator Merkley about medications when I do run into cases that cause me concern, because I'm sitting with someone and they're in tears because they can't afford their medications.
Okay.
So
Listen, yeah, well, I appreciate that comment. Thanks a lot. Next, Melissa.
See any other hands right at this moment?
Any other folks who want to tell their personal story? Okay.
Oh, we do have two hands now.
Okay.
We have
Well,
Arielle.
who was the first one that popped up?
I think Arielle Gorenson. So let me change the settings, and then Arielle, you can use your camera and mic now.
Hi.
Hi, hi, Arielle. Is this about your own personal situation?
Yeah, it's my, I was wondering if I could share some thoughts. I have experience here in the Portland area with health systems research. I'm a public health worker.
Okay, well, before you get there, we'll definitely have you share your comments. I just want to make sure if there's anyone who is here to tell their personal story about their own specific challenges that they're having with their prescription drug costs. Just want to give those folks the opportunity to speak first. Anybody else raising their hand for that? Okay, we'll give you another chance if you're still a little shy. So Arielle, why don't you go ahead?
Thank you. Thank you so much. It's Arielle, by the way.
Arielle.
And yes, feel free to record if that's helpful.
Okay.
Thank you so much for the opportunity to share. So just briefly, I've been working here in the Portland area. I live in Multnomah County. I have a degree in public health and have worked in primary care transformation for the last decade. More recently, I've been working on advancing health equity, specifically through health IT. So I've had a lot of access to data, and that's what I wanted to share a little bit about today. We all know that people of color have worse health outcomes and higher rates of certain conditions that need medication. That's very, very well documented. I read a paper recently about many health disparities and disparities outcomes involving medication access and high drug costs being a driver of the inability to access medications and obviously disproportionately affecting communities of color, which got me thinking about this board. And I think that this could suggest that that those who disproportionately face access issues around medication might also be more benefited with new drugs, new treatments, and access to those. So that's what I wanted to share. I have some links I'm happy to pop in the chat from AiArthritis, NIH. Certainly, those are the types of papers that I was looking at. And I just wanted to share that I, working in health systems transformation, I certainly understand the complexities of our system and how this board kind of fits in to help solve those. But I would certainly urge the board and the decision makers as you're approaching healthcare costs and trying to curb those costs for Oregonians for medication to mitigate any unintended consequences that could further disenfranchise these systematically disadvantaged, underserved communities, those that we're all trying to help. And I think that by engaging diverse stakeholders, similarly to how you're doing today, taking the time to do that, that's certainly a way as you're making decisions, recommendations that lead to decisions to ensure that you're not advancing one thing at the bequest of communities that have been disadvantaged in the past. So that's what I would just ask the board based on the papers that I've read.
Great. Thanks a
Thank
lot.
you.
Appreciate it.
And
Yeah.
please do drop those links in the chat because Melissa can document those for us.
I will do that. Absolutely. Thank you, Shelley.
And also, Arielle, if you would email those links, our chat's closed.
Oh, okay.
So, but our email address will be at the end of the slides. I can also give it to you right now.
Yeah, I would love that. And I'm happy to pop the links into an email.
Thank you. It is pdab@dcbs.oregon.gov. And it will be at the end of the slides. I'll put that up for you so you can see.
Thank you so much. And thank you for the time.
You bet. So I just want to again ask if there are any consumers, patients who are interested in talking about their own personal situation. If so, please raise your hand so that Melissa can see you. Okay. I think we are at the point now where if there are advocates who want to speak on behalf of Oregon consumers, we'll give you the opportunity to speak. And when I say Oregon consumers, I actually do mean Oregon consumers. I know there are issues in other states, but we are really focused. The board is focused on helping Oregon consumers. So please keep that in mind. I guess we'll go to Suzanne.
Let me change Suzanne's settings. Okay, Suzanne, you should be able to control your mic and camera now.
Okay.
Okay, Suzanne, is it all right? Suzanne, is it all right if we record your comments?
Yes. And unfortunately,
my camera is harder to control and my computer will crash if I turn that on. So
That's okay. We can hear you just fine.
really, I have a very simple question. And so I'm going to voice my question and ask you to put it anywhere in this discussion that it's appropriate. And that is hearing from Alex Johnson, it brought to mind a question of how can an insurance broker be of service to Oregon consumers. I think a lot of us don't really realize that brokers are out there and what they might be able to do. So I simply had a question. Thank you.
Okay, thanks a lot. Okay, looks like we have Luke Winkler.
Yes, let me change Luke's settings and Luke, you should be able to use your camera and mic now.
Hi. Yeah, so
So Luke, is
right
it okay to record your comments?
Of course.
Okay.
Yeah, so my name is Luke Winkler. I'm with OSPIRG. We are a statewide public interest group representing thousands of members across the state. And among other things, we advocate for more valuable healthcare in Oregon, whether that comes in the form of lower costs or higher quality. And so I'm kind of here to thank the PDAB for you guys' work on lowering prescription drug prices. As I'm sure everyone in this audience knows, prescription drug prices are far too high, and that hurts everyday Oregonians. And as a public interest organization representing people, we're constantly hearing horror stories about it from people who have to miss work and deal with migraines because they can't afford the prescriptions that their neurologist prescribes, or people who have to let their arthritis progress because they can't afford treatment, or just horrible stories like that. Tons of stories, and this is just like a small portion of it. There's so many more across the state, across all different demographic factors, and it's saddening and heartbreaking, to be honest. And obviously, the board can't fix all of the issues. I don't think any singular body could, but it's very much needed and an appreciated part of improving Oregon's healthcare. So thank you.
Thank you, Luke. So I'm going to make another pitch for anybody who is out there who would like to share their story with us. I did see a few people have come in within the last few minutes. So again, this is a time for folks who would like to share their individual story about the cost of your prescription drugs and how it's affecting you and your household. So if you have just joined us and feel like you want to share, go ahead and raise your hand, and we'll have Melissa recognize you. So it looks like Janna Parker has raised her hand.
Yes, I've changed. Janna, you should be able to use your camera and mic now.
Hello, thank you, everyone. My name is Janna Parker. I am a community health worker at St. Luke's EOMA in Baker City, Oregon.
Janna, can we record your comments?
Oh, yeah, absolutely.
Okay.
I just wanted to say I have a few stories I'd like to share just from patients that I work with. Well, like with the cost of insulin, it's terrible. And I also worked in a pharmacy for 10 years prior to coming to the job I do. So I had firsthand experience of seeing the effects of cost. But we were working with a patient when I was in the pharmacy who took insulin and couldn't afford it. So she quit taking it and she didn't say anything. She ended up in dialysis, kidney failure. So I think that that's something to consider with our elderly. They are afraid to speak up sometimes, or they don't know who to speak up to. And so they just go without, and then the health effects are detrimental and even deadly to them at that point. So that was just a story I'd like to share. Secondly, I work with a lot of patients who are needing Eliquis. And so Eliquis is horribly expensive, even if you have insurance, not even if it's Medicare, private insurance, whatever. But I try to do some patient assistance for them, and Bristol Myers and Squibb, for one, is a great one, but they are to the point where people aren't qualifying. And I don't know if anybody's familiar or not, but when you have a government funded insurance such as Medicare, Medicaid, a lot of times you don't qualify for these programs for financial assistance. And if you do qualify with having like Medicaid, sometimes you don't get it. So what I just wanted to say is that maybe there's some way we can figure out how to help like our Medicare population, or that they want to qualify for financial assistance, that there aren't those barriers that because they are funded by government that they're not allowed to apply for them, or that they fix the level of income level so they qualify for them. Because even if a patient can afford their Eliquis, let's say for 3 or 6 months of the year, they're going to hit the donut hole at some point, and then they're not going to be able to afford that medication because they're going to have to pay out of pocket until they get out of the donut hole. And so I just kind of wanted to bring that up to people's attention.
Great. Thanks a lot, Janna. You know, your comment about the impact of folks who can't afford their medication and then they don't take it, you're echoing a comment that we heard in Medford, and it probably should be another slide in the presentation because it does impact the system. If someone ends up in the emergency room or in urgent care because they haven't taken their prescription drugs, it's not only impacting them, but it's actually costing the system as well. So thanks for those comments.
Thank you.
Okay. Melissa, do we have other folks?
We have Tiffany. See, I think we
Okay.
just lost Tiffany. Tiffany, if you're here, I'm not sure what happened. I think we just lost you. But put your hand back up if you would still like to speak. So I'll go ahead and move on to Scott. Would that be good, Lou, to move on?
Sure. Yeah, let's do that. And
Tiffany
we can get
come back.
Tiffany. We can get Tiffany next.
Okay, and Scott, you can use your camera and mic now.
Yeah, hey, I'm in the same thing. Here, let me try that. There we are.
Okay. Scott, is it okay to record you?
Oh, absolutely, certainly. I would appreciate that. And I'm speaking on behalf of Oregonians as well. You know, many years ago, I was also our Washington State's HPG co-chair. So we worked a lot with state AiDAP associations and some of the concerns that we had for Oregon. And we work a lot with CAP, Cascade AIDS Project, right? That has a 340B program that works within this field of the HIV ecosystem. And we're really glad that the PDAB is having conversations with its partners in Oregon through OHA to talk about how any upper payment limit considerations may have for some of the AiDAP association like ecosystems of how that will play out for patients. And to the previous speaker's conversation about what are the potential additional costs to the healthcare system to support potential switches if patients are faced with upper payment limits that may affect them through one of the drugs that you're looking at, which is Biktarvy. If they're forced to switch to like a multi-tab regimen, there could be some additional cost to the systems. And I would want to place just some emphasis as we look at that long-term scope, whether or not patients with high acuity, that they're given some special consideration and during that switch period that would have more direct and intensive case management involvement to ensure that continuity of care. So we're really happy that you're having a conversation with CAP and the AiDAP, and we would hope that that conversation gets played out for the rest of the community, because there's obviously more HIV individuals than Ryan White. There's a lot of people on Medicare and Medicaid, and there's a lot of churn, and CAP does an amazing job, as does other, Oregon community-based organizations. So I would just say, make sure that we think about some of those medication pickup logistics and switch needs. And that's
Great.
all. Thank you very much.
Great. Thanks a lot, Scott. Okay.
Now to Tiffany. All right, and Tiffany, you should be able to use your camera and mic now.
Okay, great. Can you hear me?
Yeah. So is it okay to record you?
Absolutely.
Okay.
All right. Well,
Go
first
ahead.
of all, I just really want to thank you all for this opportunity to have patients and caregivers come forth. I am representing people in Oregon. I'm also a patient. I have axial spondyloarthritis. I use biologics. I thankfully can afford my medication because of the copay assistance plans, but I also know there are a lot of patients, including ones that we represent in Oregon, who do struggle to pay for their prescriptions. And what I really just want to thank you all for is asking a very important question. What is the name of the drug that you are having trouble affording? I think that has really been missing in some of the PDAB conversations around the country. We need to find out what is expensive before picking drugs, that are maybe expensive for the state, but then a lot of money is spent. And just to find out that a lot of them have copay assistance, for example. One of the things that I did want to clarify, because a lot of patients I know really are struggling with, as we heard before, with Medicare. And I understand in most states with the PDABs that Medicare isn't covered as far as something that can be reviewed or talked about in the PDAB. I just wanted to clarify that. And if it's not, I think the second component that I'd like you to think about as you're asking these questions of what's expensive, I think the why is super important. Because if it is Medicare and if it can't be addressed, then that maybe is a recommendation or something that can be passed on. So I just wanted to make sure that we're asking the why as well. So thank you for this time. I appreciate it.
You bet. Thanks a lot, Tiffany. So anyone else who has their hand raised? Okay, Loren looks like she has her hand raised.
Okay, Loren should be able to use camera and mic now.
Thank you. Nice.
So Loren, is it okay to
Yes,
record your comments?
absolutely. Yeah,
Okay.
absolutely. Thank you again for having this. Loren Sandt with the Caring Ambassadors Program. And this whole conversation brought up a question for me that maybe you should add into your survey is, what is your tier of your drug on your plan? So that like, yes, I'm on a 50% tier. That makes a big difference of whether a drug is affordable or not. So when you're
maybe you should explain, Loren, maybe you should explain that for others, what you mean by tier, okay?
Sure. So every insurance plan has different levels that they pay for your drugs, and their drugs are on a tier like 1 through 5. And the most expensive drugs are generally on a tier 5. And your copays depend on which tier your drug is on. And so if you have a plan that, for instance, I have a very expensive cream I get, and on Blue Cross Blue Shield, it was a tier 2. On United Healthcare, it's a tier 5. I'm now at 50% copay for that cream. Makes a big difference to know what tier a drug is on. So when you're doing the survey, sort of understanding what's covered. And then if they're on Medicaid, are they on a CCO and which CCO? Because they have their own formularies as well. And so give you guys just a little bit more information on what you're trying to collect. But greatly appreciate your time. And I think the gentleman that spoke earlier about with MS, that, he's on a high tier, his drug was on a high tier. And so it was very unaffordable for him. And so that just will help you understand it more, because not all drugs are covered equally. So thank you.
Great, thanks a lot. And anyone else who would like to share during this time? Shelley.
Hey, I couldn't be here without also trying to be a useful helper to those that have presented information. So this is a direct just comment I wanted to share with Janna, because she was referencing how she goes above and beyond and really helps people seek solutions. I've been actively listening to everyone, but also trying to look at Eliquis solutions myself with the resources I have in my professional background. I wanted to also make sure, Janna, that you're personally aware of AiArthritis, which is a solution of kind of a drug discount support solution that's in consortium with a few states, and Oregon is one of them. So I just wanted to make sure that for anyone either listening to this recording in the future, as well as to directly help the people that Janna's been supporting, that I wanted to make sure that I just shared information related to AiArthritis. I know this is a listening session. This is just me sharing this information as a personal individual. not on behalf on the board. I also am not framing that AiArthritis is a solution to any of the things, but I can't participate in something at a personal level and not help someone where I think I can help. So just wanted to share that information.
Thanks a lot. Thanks a lot, Shelley. Any other comments that folks want to give now? So I just I want to make sure that folks who came in later after the overview that you folks know that very soon this session will be online at the excuse me, not online. It will be on the PDAB website, so you can go back and look at the overview if you've missed it. So final call for anyone who would like to share their comments. John Mullin.
John, you should be able to use your camera and mic now.
Okay.
John,
Hello.
is it okay to record you?
Very much. Yes, that's good. Go ahead.
Thanks.
My name is John Mullin. I'm board president of the Oregon Coalition for Affordable Prescriptions. I just have a couple of really quick comments. For anybody that spends any time looking at the chart that Lou put out that he equated to the back of a television screen, and I'm old enough to remember those configurations. But the point of all of that is just looking at that and understanding the complexity of the situation that we're in as a country, as it affects both providers, consumers. And the Oregon Coalition for Affordable Prescription has basically two main issues that we work on. One is industry transparency, so understanding the back of that television screen. And then also the important primary goal is affordability, and that affects both purchasers as well as consumers. So I would simply just like to encourage anybody that's interested to learn more about what OCAP's work is about. We do have a website. We also do have a Facebook presence. We're interested in stories. We're interested in what consumers have to say. I would just point out that we don't receive any funds from the pharmaceutical industry. And we are also not individually advocating for particular drugs. We're interested in making sure that affordability is something that we can reach in Oregon and make it better for the people who are struggling to afford the price of their prescriptions. So with that, I would just say thank you again for having these fora. I used my 3 years of high school Latin to come up with the plural, but I'll be back on again at the final entity, final discussion. And I was present at the Portland discussion. It's interesting to know that even though we have literally thousands of Oregonians that are struggling with affordability, the task of getting people to show up and tell their stories is difficult, both in terms of time, but in terms of the personal vulnerability that people put forward in telling their stories. So I just want to say that while this is very important, I'm very appreciative of the fact that Shelley has been present here, because PDAB doesn't often hear from consumers. They're doing really important technical work. So I'm happy that these discussions are taking place, and thank you for the opportunity to say hello today.
Thanks, John. Thanks a lot. Any final comments that people have? Okay. Melissa, let's go to the next slide then. So one of the board's primary responsibilities is to conduct drug affordability reviews and make recommendations to the Oregon legislature. And this happens at board meetings. The board has gone through a process outlined in its administrative rules to prioritize and select the drugs it will review this year. And this is a schedule of the board's review process. It has the date the board will do the review, the name of the prescription drug, and the main treatment. In other words, what condition the drug is treating. And this is available on the board's website. So again, the board will be making recommendations to the legislature. It will not make decisions on cost setting. It doesn't have the authority to do that. Next slide, Melissa. So in its review of the drugs listed in that slide that we just showed you, PDAB wants to hear from consumers at its board meetings. To do that, you need to sign up. Folks have asked why that's necessary. Well, board meetings have been Zoom bombed. And I think a lot of you probably know Zoom bombing is when someone comes online for the purpose of disrupting the meeting. And it's unfortunate that people need to sign up, but as a courtesy to everyone who's given their time to attend, the board really feels that it helps with the discussion to be able to sign up. So if you want to attend a board meeting, you can go online to the PDAB website. If anyone has any problems getting online, Melissa is happy to help you with that. Her phone number is on that last bullet that you see. And so she's happy to help you walk through it if that's a problem. Next slide, Melissa. So if you'd like to submit oral or written testimony, there's a public comment form online. The board would like to receive written testimony in time to consider it for their discussion. But if written testimony is received after that board meeting, the board is still happy to consider it up to 72 hours before its November meeting. So if you missed the timeline, we hope you wouldn't, because it's important for the board to review those comments when they deliberate about and discuss. But the board is happy to hear from you after that as well. So for oral testimony, signing up helps the board to know how many folks would like to testify. Next slide. So we thought we would end up with this last slide that has the icon that will get you directly to the PDAB homepage. And so here's the link as well, and the phone number. So thanks to everybody who has attended the forum today. Please let other folks know about the online forum next Tuesday, May 14th from 6 to 8 p.m. There is a copy of the flyer that we've sent out to a lot of folks on our website with the Zoom link. And if folks can't attend this next forum, the survey is online as well, as I mentioned earlier. So just even encouraging folks to fill out the survey would be a big help, and give them an opportunity to express their concern about the high cost of their prescription drugs. So with that, we will end the forum today, and thanks again to everybody for all your participation. Take care and have a good rest of the day. Bye-bye.